Hi, I'm Dr. Laura Morris. I am a breast surgical oncologist at the Cancer Center and the Retreat. I grew up in the Detroit area. I went to Wayne State University for my undergraduate degree and then Michigan State University College of Human Medicine. I did my surgical training at Beaumont Hospital in Royal Oak and then my breast surgical oncology fellowship at Michigan State. I was on faculty there for 5 years until I was recruited by Goshen to come down here and set up their breast oncology program. The scope of a breast surgeon's practice is basically anything. It's women who are at high risk for breast cancer, women who have family members. It doesn't even cover breast cancer. I would say 70% of women that we see do not have cancer. We see young girls, we see teenagers who are just starting to develop, we see women who have questions during their pregnancy. So anytime a woman is uncertain or her provider is looking for reassurance or a second opinion is appropriate. Sending the patient to us and letting us do the workup may be the most appropriate, particularly for breast lumps or concerns that a patient has, because that way we can see the imaging right away and then we can go ahead and decide if the patient needs the biopsy and get all of that done, usually a little more expeditiously than a primary care provider can do. Breast surgical oncology is on site with the breast imaging equipment. So we have our tomo mammography units there, we have our ultrasound, we have a bone density, as well as our stereotactic table. Everything we do is all right there, and we also work with the radiologists who are there. So if we see a patient and we need imaging right away, we have access to that. And we also can do the biopsies that we need to do with the imaging equipment. What is unique about the breast surgical oncology team in Goshen is that we actually do image-guided breast biopsies. Nowhere else in the region, I know specifically, are any of the surgeons doing their own stereotactic biopsies or ultrasound-guided biopsies. So that's why we can take the patient from an abnormality to the end of the workup, if you will. Our pathology results are 24 hours turnaround, which is good because the hard part is waiting. And then if it's not a cancer diagnosis, we can decide what the appropriate follow-up plan is. And if unfortunately it happens to be a cancer, we are on top of it. I'm also board certified in lifestyle medicine, so I like to address with the patient what they can do from lifestyle changes to reduce the risk of a breast cancer or reduce the risk of a recurrence or even reduce the risk of other chronic diseases that we get, including heart disease and obesity and hypertension. Their activity, what are they eating? Are they sleeping well? Do they have stress? Looking at those types of things I always address with my patients. What's special about having fellowship-trained breast surgical oncologist is coordination of care. There are certain breast cancer patients that you shouldn't be operating on right away. You should be sending them to medical oncology for preoperative chemotherapy. You should be able to coordinate care with a plastic surgeon up front and not doing a mastectomy and then the woman saying, well, no one told me I could have reconstruction, and then she's lost out on some of her reconstruction options because it wasn't combined with her initial surgery. So it's special from the standpoint that we see things from a lot of different sides that surgeons who didn't do specialty training perhaps didn't see in their training. The operation itself might not be the part that needs to be addressed, but the total patient care and how is it integrated.